Dear students, I am Professor Ayman Madani, Professor of Otolaryngology. Today we are going to talk about the nasal masses, the diagnostic tips, how to have a preliminary diagnosis of a nasal mass. You can see here that the nose and the paranasal sinuses, they have different types of structures. They contain bone, ligaments, cartilage, vessels, olfactory epithelium, respiratory epithelium, vibrissae, glands, lots of structures. It means that we can have different types of masses that can arise from the nose. These are few examples. These are again another example of the different masses that can arise from the nose. Now, what is the importance of preliminary diagnosis? It's very important when you look at a mass that you have a plan in your mind what you are having in the nose of this patient. The importance of preliminary diagnosis are the urgency of dealing with the problem. Very important. Is it something urgent you have to deal immediately, or it is something which can wait for some time? Again, you have to determine the needed investigation. Some masses are vascular, some masses are osseous, some masses they don't need an MRI, some masses you need an MRI. Also, the applicability of office procedures. Some masses you can take a biopsy from, while others you cannot do such a thing. Different classifications have been put. The one which is widely accepted is the anatomical one, or the classifications. This is the nose. You can see that you have an eye here. Around the eye, superiorly, medially, and inferiorly, you have the paranasal sinuses. If you look at the skull, this is the eye, this is the ethmoids, this is the frontal, this is the maxillary sinus, this is the nose and the nasal. If we have a diagram of this, you can see that the nose has a roof, it has a floor, it has a midline structure, which is the nasal septum, and then the lateral wall constitutes of the eye or the globe superiorly, the maxillary sinus inferiorly, and then there are structures which are present inside, which are the nasal. For the diagnosis of any nasal mass or any diagnostic paradigm in medicine, you will have the history, that's to say what the patient says, and then examination, the signs, what you find on examination, and then finally the investigations if you want to confirm diagnosis. This is the method we used to examine the nose in the past. This is what we call the anterior rhinoscopy. This is the mirror. This is the headlight. This is very old now lights. Now we have the era of the nasal endoscopy, where you can have the endoscope. This is the endoscope to be put inside the nose to see inside. As regards to the imaging, on the left side you have the plain X-ray, on the right you have the CT scan of the paranasal sinuses. In the year 2020, the plain X-ray has nearly no role in the diagnosis of sinonasal disorders. See the accuracy of the CT scan in the diagnosis. When we classify the masses, we have two nostrils and a midline structure, which is a septum. So any structure, any mass arising within this cavity could arise from the midline. The commonest is the septal hematoma and septal tumors. Or it could arise from both sides of the nose, bilateral lesion, the diffuse sinonasal polyposis in the turbans, or could arise from one side of the nasal cavity, and this one ranges from the very benign antrochoanal polyp to benign tumors, inverted papilloma, vascular tumors, angiofibromas, and then comes the malignant tumors. So you can see here that the most important is the unilateral structures, because unilaterality can lead to variable structures ranging from the very benign one to the very malignant. As I have said before, this is the septal hematoma. It's a midline structure. Usually it follows trauma or sometimes post-operatively, like post-septal surgery. You will have a sudden or acute onset bilateral nasal obstruction. If you neglect this septal, can be infected, leading to an abscess. The abscess will lead to cartilage erosion, and we will have this saddle-shaped deformity or saddle nose deformity, which is the complication of a neglected hip. The unilateral masses you can see in this diagram. This is one side of the nose. You will have structures either arising from the roof. When we say that the roof of the nose, this means that the floor of the brain, or arising from the floor of the nose, that's to say the roof of the palate, or arising from the septum, septal masses, or could arise from the lateral wall of the nose. The commonest are the antrochoanal, the inverted papillomas, the angiofibromas, and the first structure arising from the septum. We have the bleeding polyps of the septum. These are like small vascular malformation or small hemangiomas, easily to be removed even under local. Masses arising from the floor. We have the commonest thing, which is called the nasoalveolar cyst. It elevates the floor of the nose, as you can see. And the approach of these masses is very simple. You can approach these masses via a sublabial incision like this. Again, the encephalocele, these are masses arising from the brain herniating inside the nose. You can see here the defect in the nasal roof. Here, this is a brain tissue coming from above to below, a brain tissue coming from above to below. These patients are usually having what we call a clear rhinorrhea coming from the nose. Clear rhinorrhea, clear rhinorrhea, clear rhinorrhea. This clear rhinorrhea is what is called the CSF rhinorrhea, which is very salty. And if you do a beta-2 transferrin or a beta-trace protein, then it comes positive for. As regards the inverted papilloma, as you can see here in this slide, it arises from the lateral nasal wall, usually at the junction between the lamina papyracea and the roof of the orbit. It is an irregular, as you can see here, it is an irregular mass arising from this antrochoanal polyps. This is a smooth surfaced mass that arises from inside the maxillary sinus and then gets in. It's a very smooth surfaced mass. It can go on also through the choana into the nasopharynx, as you can see. The third mass, which is the angiofibroma, this is a vascular tumor that arises from the area behind the maxillary sinus, which is the pterygopalatine fossa. This mass usually has a hemorrhagic petechiae, as you. This is the area of the pterygopalatine fossa, which lies behind the maxillary sinus. When you have on imaging, you will find that the posterior wall of the maxillary sinus is pushed anteriorly. This is what we call the Holman-Miller sign. This here, the angiofibroma, arises in this area just behind the maxillary sinus, and it widens the sphenopalatine. What about malignancies? We have different types of malignancies that can arise into the nose: squamous, adenoid cystic, mucoepidermoid, hemangioperi, and melanomas. Actually, when I teach you the entity of malignancies, Each of these types of malignancies has its own peculiar behavior. It is beyond the scope of your study to know the peculiar behavior of each of these. But what's the aim of this lecture is how or when you suspect a malignancy. Tumor arising in the nose does not respect the boundaries. It invades in all directions. It can go into the mouth, it can go into the nose, it can go into the eye, intracranial, or can go anteriorly through the skin. These are all examples. Look at this. The nose is broadened, very broad nose, and there is an erosion of the palate. Another mass affecting the eye, ophthalmoplegia. Look at this, palatal perforation due to the mass. This cutaneous fistula. Here it is, the osteomyelitic changes due to the of the mass. Finally, what about the bilateral masses? We have two entities, the inferior tuberate hypertrophy, which is bilateral, or the diffuse polyposis. When we talk about polyposis, we are talking about two entities, either the solitary polyp, which is the antrochoanal polyp. We have just talked about it. It arises from the maxillary sinus and then into the nose to the nasopharynx. That's why it is called antrochoanal polyp. The multiple polyps, we have the entity of diffuse polyps filling all part of the nasal cavity, or middle meatal polyposis arising only from the area of the middle meatal. This is an example of what we call the diffuse sinonasal polyposis. As you many etiological factors. Look at this slide. You will have 6 factors that cause the diffuse polyps to arise. In this slide, you have another 3. So this means what? This means that we don't have a clear etiology of these polyps. That's why when we operate on these polyps, we are dealing with the polyp itself, but we are not dealing with the cause. That's why the recurrence is. They can arise anywhere in the nose, however, the common site. This is the CT scan, how it looks in cases of polyposis. How we manage these polyps? We have the sandwich technique. Medical treatment is the main line of treatment. When medical treatment or maximal medical treatment fails, we can go on for surgery. We have what we call the functional endoscopic sinus surgery to remove these polyps, and then you will have to continue the medical treatment. These are an example of the medications we use. Most important is the steroids, whether given topically or systemically. We can also, the antihistamines are very important in this. Surgery, we have what we call functional endoscopic sinus to remove the polyp. When we do the surgery, when we use the medical treatment and it fails, or if we have to use prolonged steroids in a systemic way, or quality of life changes with medical treatment, especially with the steroids, or the patient who started to have complications. What about the alarming symptoms when we look at a nasal mass? If we have a persistent unilateral, very important, unilaterality and the persistence of the symptoms. Persistent unilateral nasal obstruction, persistent unilateral watery rhinolea, persistent unilateral epistaxis, sinus pain, or extranasal manifestation, which represents the malignancies in such. Thank you very much, colleagues.